Hello friends, now let us continue the previous class which was on hypermetropia. Now we have completed the clinical types of hypermetropia, which include simple or developmental or physiological hypermetropia, non-physiological hypermetropia. Again, in non-physiological hypermetropia we included congenital hypermetropia and acquired hypermetropia. So all these are the different types of hypermetropia which we have encountered right now. So now coming to components of hypermetropia. What are the different components of hypermetropia which are to be known? Are there any different components of hypermetropia which are new to you or new to me and learning stuff? So what is the first component of hypermetropia? So one is total hypermetropia. What does total hypermetropia include? Total hypermetropia generally includes the total amount of refractive error, that is total refractive error which a person's eye has after complete cycloplegia with atrophy. Total refractive error which is measured after atropine administration that is called as total hypermetropia, right? This total hypermetropia is again of two types. One is latent hypermetropia and the other one is manifest hypermetropia. In latent hypermetropia, here the hypermetropia, it is the amount of hypermetropia which is corrected by ciliary muscle tone. That is called as latent hypermetropia. You know, if one has hypermetropia, the ciliary muscle tries to adjust the lens in such a way that a person can see it properly. So this latent hypermetropia is the amount which is seen in diopters corrected by ciliary muscle tone. You know, ciliary muscles have tone and they adjust the lens in such a way that their optic error is corrected, right? So this is latent hypermetropia. This latent hypermetropia, it is high in children. It is high in children and it decreases in adults, right? This latent hypermetropia is high in children and decreases in adults. So this latent hypermetropia, it is only and only disclosed, or it is only and only seen if refraction is done after abolishing the ciliary tone. After abolishing the ciliary tone with atropine. Once you administer atropine, the ciliary muscles are paralyzed. So the tone of the ciliary muscles is decreased. Thus, it can be seen only and only when administration of cycloplegic, right? So seen only after atropine. Once you give atropine, then you can see it, right? So this is latent hypermetropia. Now coming to manifest hypermetropia. It is the remaining portion of hypermetropia which is not corrected by ciliary muscle. No correction, right? And it is now of two types. So the first type is facultative hypermyopia, or the second type is absolute hypermyopia. Facultative hypermyopia, it is basically that part which is corrected by patient's effort. Like this is corrected by patient's efforts. Like the patient tries to correct it. Right? So that is facultative manifest hypermetropia. Absolute hypermetropia, no correction at all. Right? So this is absolute. This is no correction by mainly ciliary muscle. Because you may get confused why again I wrote no correction above and below. There is correction by patient's effort. So this is no correction by ciliary muscle, which is of again two types, facultative and absolute. Facultative, it is basically corrected by patient's efforts. If absolute, there is no correction at all, right? So this is about the facultative, latent and manifest hypermetropia. So totally we can say that total hypermetropia is equal to latent plus manifest hypermetropia, right? So this is majorly measured after atropine administration. Now coming to the relationship between age and hypermetropia. What I would like to say is there a relationship between age and hypermetropia? If yes, what is it? So let's see. At birth, how is the eyeball? At birth, eyeball is short, right? It is short and it has +2 to +3 hypermetropia. Okay, let me write here hypermetropia, right? It has power +2 to +3 hypermetropia at birth. And now at the age of 5 to 7 years, what happens? Basically this power, which is +2 to +3, gradually decreases and becomes 0 or emetropia, and the eyeball size is generally normal. And at old age, what happens? Greater than and also 5 to and then to 50 years, up to 50 years. Even up to 50 years, the eyeball is normal and it is emetropic. And once it crosses 50 years, that is after 50 years, it is short again with +2 to +3 hypermetropia, right? This gradually increases. This again increases. So this type of hypermetropia is called as I have said, it is senile hypermetropia. In my last class, I have already said that Senile hypermetropia is mainly due to two reasons. One is curvational hypermetropia and the other is index hypermetropia, right? So this is senile hypermetropia. So generally, if you see the relationship between the hypermetropia and age, at both extremes of age, that is at birth and at 50 years of age, you can see that the eye is hypermetropic, whereas between the birth and 50 years the eye is ametropic. So this is the difference, this is the relationship of age with hypermetropia. So now what are the clinical features? These are all the clinical features we all might have suffered at one stage or the other who have hypermetropia. The first symptom is asymptomatic. There is no symptoms at all, because as I have said, our eye tries to make some accommodative effort, so making it asymptomatic. The second type is asthenopic symptoms. What are these asthenopic symptoms? These asthenopic symptoms are basically tiredness of eyes, tiredness of eyes is one, or it may be headache, watering of eyes, mild photophobia. It may be mild photophobia, tiredness of eyes, headache, watering of eyes, or it may be mild photophobia. All these are called as asthenic symptoms, which are associated with hypermetropia. The next is defective vision. So what are the defective visions plus asthenopic symptoms? This defective vision can be with asthenopic symptoms, or without asthenopic symptoms. If you see defective vision with asthenopic symptoms, here the defective vision is basically not able to clearly see near objects. They are not able to clearly see near objects, right? So this is defective vision plus asthenopic symptoms, or there may be only defective vision, right? There may be defective vision with asthenopic symptoms or only defective vision alone. So all these are the clinical features of hypermetropia. Effect of aging on vision. What is the effect of aging? As I have said, with increased age, what happens? We have seen physiologically, but let's see in hypermetropia. Increasing age. Whenever there is increased age, one, there is decreased accommodative power, right? Increase in age leads to decreased accommodative power because of decreased activity of ciliary muscles and decreased activity of different parts of our eye, leading to decrease in vision, which leads to hypermetropia, right? All these are the major clinical symptoms of hypermetropia. One is asymptomatic, next asthenopic symptoms, which include tiredness of eyes, headache, watering, mild photophobia, that is intolerance to light, and there may be defective vision, that is not able to see clearly the near objects, and this defective vision is may be associated with asthenopic symptoms, or there may be only defective vision. Okay, all these are the clinical features. Now coming to signs. Right, signs. 1, size of eyeball. Size of eyeball will be small. Right. Next, cornea. One, size of eyeball will be small. Cornea will also be small. In hypermetropia, all those will be small. Cornea is small. Because of smaller and eyeball and cornea, anterior chamber is shallower. Right, anterior chamber will be shallower. The fourth one is retinoscopy. If you do, and autorefractometry, retinoscopy and autorefractometry, all these are the experiments which you do in your all these are the instruments which are present in ophthalmology. If you do retinoscopy and autorefractometry, this shows hypermetropic refractive error. Right. And fifth, fundus examination. If you examine fundus, what will you see? In fundus, first you see optic disc. Optic disc looks small. 1. Vascularity will be seen increased, and there will be ill-defined margins. Right. And there may be greater light reflections. Right, there may be greater light reflections leading to shiny retina. Because of greater light reflection, there may be shiny retina seen. Next, sixth one is A-scan ultrasonography. What is A-scan ultrasonography? This is a type of ultrasonography which we do in ophthalmology, where we see in hypermetropia we see short anteroposterior axis. Right, anteroposterior axis is seen short, especially in axial hypermetropy. So these are the different signs of hypermetropy, where the size of the eyeball is small, cornea is small, anterior chamber becomes shallower, retinoscopy and in autorefractometry. These are the different instruments. In these instruments you can see the refractive error clearly. On fundus examination you see optic disc is small and increased vascularity, and you can do A-scan ultrasonography. There you see short anteroposterior axis. Excuse me. Now let's discuss the grading of hypermetropia. Coming to grading of hypermetropia, it is of three types: low, moderate, high. Right? If it's low hypermetropia, it is less than or equal to plus 2 diopters, plus or minus 2 plus 2 diopters. Sorry, it should be plus hypermetropia. If it's moderate, then it is plus 2 diopters to plus 5 diopters. If it is high, it is greater than or equal to plus 5 diopters. So this is the grading of hypermetropia. Right? So now coming to the complications of hypermetropia and treatment is what is left in this part. So in our previous class we have done about different types of hypermetropia, and now we have completed the components of hypermetropia, which are total hypermetropia, which is of two types. One is latent and manifest. Latent is the amount in diopters. This is D. Sorry, it looks like 0 in fact. Amount in diopters which is corrected by ciliary muscle, whereas manifest is no correction and it is again of facultative and absolute. Now age related hypermetropia, how it is for birth, 5 to 7 years, up to 550 years, all this is dealt, and clinical features are already dealt twice, and these are the signs of hypermetropia, grading of hypermetropia. So now coming to the complications of hypermetropia. So let me deal with the complications of hypermetropia first. So what are the complications of hypermetropia? The complications of hypermetropia include: 1. Recurrent styes or blepharitis or chalasia. All these are some of the problems which occurs in the eyes, and these are mainly because of repeated rubbing. Due to eye stenopic symptoms, we repeatedly rub our eyes, which leads to styes, blepharitis and chalasia. It may also be due to accommodative, or it may also cause convergent squint. Right? Accommodative convergent squint. And it may also cause amblyopia. That is not correct vision. Next, it may also predispose to primary narrow angle glaucoma. Right? It may cause primary narrow angle glaucoma. So it may cause recurrent styes, blepharitis or chalazion, or accommodative convergent squint, amblyopia, primary narrow angle glaucoma. All these will be basically dealt in their subsequent chapters. Then you will know clearly about complications. Right now you don't understand anything about complications, so just try to remember them if possible, or else just leave it for the end, so that you will understand why each of them causes it at the end. But right now you don't even know the conditions. Without knowing the conditions, you don't understand it. So what are the treatment aspects which is important? So one is spectacles, right? that is prescribing glasses. So now, what are the rules of prescribing glasses? 1. Hypermetropia should always be discovered only under cycloplegic drug. So 1. Cycloplegic drug administration. To be done, right? Only and only then we will know the different, how the ciliary muscle, because in most of our cases the ciliary muscle tries to accommodate it and does not cause any symptoms, especially any blurring of vision in the earlier stages. So administration of cycloplegic drug like atropine will give you correct readings. Spherical correction is first needed. Spherical correction is needed. 1, 2, and the third major symptom or major mode of prescribing lens is there may be increase in spherical correction. So the patient should be asked to come again after 6 months or some interval to get his eyes checked up well. So if there is increase in correction, at 6 months, then this is definitely a case of hypermetropia, right? And the fourth thing is, if there are some other pathologies along with this, then this should be treated accordingly, right? Along with other pathologies, you should treat even this accordingly. So these are the different modes of prescribing glasses. And the second is prescribing lens. Prescribing lens. So what type of lens do you prescribe and everything? Lens mode, right? The first is spectacles. You can prescribe spectacles, which is more easier and safe, easy, comfortable, and the second mode of prescribing is contact lenses. These are basically for unilateral hypermetropia. Hypermetropia. For unilateral hypermetropia, we can mostly use these contact lenses, and these are prescribed only after stabilizing the sight. That is, it is possible that the person's refractive power may be changing every time, or the power of the lens should be increased. So this is only and only prescribed after stabilizing the power, right? all these others, these are the important treatment modalities, which are spectacles and contact lenses, which you can prescribe or you can use. So this is the major part which we have covered in hypermetropia. So there are any mistakes which you come encounter in my lectures, or if there is anything which I should change, you can comment it. And thank you for listening my lecture. Thank you.